Good afternoon. Good afternoon and welcome. Glad to see our colleagues and students joining us for this summer installment of the Health4Her seminar sponsored by the Center for Applied Research and Evaluation in Women's Health here at East Tennessee State University. My name is Amal Khoury, and I am delighted, to welcome you all and to welcome our guest speaker today, a longtime friend and colleague and women's health researcher and provider who is joining us today from Pennsylvania. Dr. Cynthia Chuang, we are very excited to have you with us today. Thank you for taking the time to join us. Dr. Chuang is a professor of medicine and public health sciences and is also chief of the Division of General Internal Medicine at PennState College of Medicine and Hershey Medical Center. She is not a busy individual at all. In fact, Dr. Chuang is both a practicing physician and a researcher scientist who is equally committed to providing the highest quality care to her patients while leading research studies to advance women's health and healthcare with a focus on reproductive wellness. And because being a clinician and a researcher is not, enough, Dr. Chuang also assumed responsibility for leading the Division of General Internal Medicine at Penn State. And in that role, she oversees and directs a large team of physicians and scientists who are engaged in educational and research programs. Dr. Chuang completed her MD at New York University School of Medicine, then went on to complete a residency in internal medicine at Temple University Hospital, and from there to Boston, where she completed both a fellowship and a master's in epidemiology at Boston University. Her work has been funded by the NIH, by AHRQ, by PCORI, and other agencies. And today, she will be sharing with us hot off the press findings from her R01 on how contraceptive policies influence access to contraceptive care. So thank you again, Dr. Chuang, and we are looking forward to learning from you.
Thank you, Dr. Khoury. It's such an honor to be here. Thank you to you and to the Center for Applied Research and Evaluation in Women's Health. It's really an honor, so thank you. Like Amal said, we've been acquainted for many years. She's visited us here in Hershey, Pennsylvania. Certainly familiar with her work and actually work of several of those in the center. So my gosh, it feels great to be amongst colleagues who study similar things. So after I got Amal's invitation, I took a look at the Care Women's Health website, and my gosh, I feel like this is such a friendly place. I think about my own personal research mission as hoping to develop good research evidence that informs health policy around reproductive equity and well-being. And I feel like when I was reading about the mission and vision of Care Women's Health, it was very similarly aligned. So it's great to be here. Like Amal said, I'm looking forward to presenting some of our recent work, but given that I'm amongst a group of experts, I hope that actually we can have some good discussion and exchange of ideas as well, because I hope to learn from this group today as well. So, okay, so let me start sharing my slides. Oops, hold on. Okay. I assume you can see the slides now. Okay, good. So I'm going to start sharing, and since I am from a different part of the country, I'm going to just give you a little brief intro into where we are here at Penn State College of Medicine. So on the left part of the slide, you can see a map of the blue area is Pennsylvania. So we in Hershey are considered to be part of central Pennsylvania, but we're actually closer to the eastern part of the state than the western part of the state. We're about 80 miles to the west of Philadelphia, and about 180 miles to the east of Pittsburgh. In spite of being closer to the eastern part of the state, for some reason we have way more Pittsburgh Steelers fans here than we do Eagles fans. I haven't quite figured that out. But anyway, we're very close to Harrisburg, as you can see, which is the state capital. Hershey itself is a pretty small town. We have 15,000 population, and it houses Penn State College of Medicine and Hershey Medical Center. I suppose that if any of you have been to Hershey before, it might have been to visit some of our other attractions, not the medical center or the College of Medicine, but we're probably very also well known for being home to the Hershey Chocolate Factory and to Hershey Park. Hershey Park, Hershey Foods, and the Medical Center are by far the largest employers in our area. You may also be more familiar with State College, which is where Penn State main campus is housed, and we're about an hour-and-a-half drive away. State College is to the north and to the west of us. So that's just my little introduction to where we are here in Hershey. I thought that some goals for today, since we're going to be talking about the impact of policies on contraceptive use and behavior, I thought it might be a little fun to talk a little bit about the history of contraception and the history of contraceptive policies. Since we're here to talk about how do we study the impact of contraceptive policies, I think it's really interesting to think about, where contraceptive policies have come along the way. And then I'm going to present some data based on our analysis looking at the impact of federal policies on contraceptive use and costs. I'm going to set up some information about state policies and costs. Those analyses are still ongoing, so I'm optimistic that maybe Dr. Corey will invite me back one day and we can talk about some future analyses. And then I would be really interested to end our conversation today to talk about what might be on some of our minds, which is what the implications are of if Roe v. Wade gets overturned. What can we be thinking about as researchers in terms of the effect it may have on contraception, contraceptive policies, contraceptive access, and would love some ideas from this group in terms of how we can be best prepared as researchers ourselves. So why don't we go ahead and get started, and feel free as I go if you want to throw questions or comments into the chat. If I can, I'll address them as we go, but certainly we can kind of use that to remember what topics we want to come back to at the end. So please feel free to do that. Okay, so obviously we could spend the whole hour talking about unintended pregnancy, but given the expertise in this group, I decided just to make one slide that said unintended pregnancy on it and not have a whole lot more than that, since I don't think this group needs a lot of background about this. But just to level set ourselves, just to remind everyone that, nearly half of the pregnancies in the United States are unintended. And we know that unintended pregnancies has, several untoward consequences, including delayed prenatal care, prematurity, We know that there's negative physical and mental health consequences for both pregnant women and for their offspring. We also know that there's significant social and economic impact to unintended pregnancy. Most individuals and couples want to plan the timing and spacing of their childbearing. And so unintended pregnancies can have significant impact on folks. It's also associated with lower educational attainment and career attainment in women who have unintended pregnancies. And it's really costly. So we know that 70% of unplanned births are paid for by public insurance programs, primarily Medicaid. And so the total public expenditures resulting from unintended pregnancies is estimated to be $21 billion per year. So very, very costly. So we know that we have, quite effective methods of contraception that can be used to prevent unintended pregnancy, but we are also very aware that there are many barriers to effective contraceptive use. And so the way I often think about what those barriers are and why do unintended pregnancies happen, this is one of those areas that I'm really interested in some discussion from the group, is how we as researchers, not just researchers, but the public, a society, thinks about why unintended pregnancies happen. So I tend to, I guess in my research proposals, frame it with a socio-ecological model, but I'm curious how other folks might think about it. So I think about this, the Guttmacher Institute explains that on average, US women on average generally want to have 2 children. And so that means that that's about 3 years spent trying to get pregnant, being pregnant, or being postpartum, which leaves about 3 decades of the average reproductive lifespan trying to avoid an unintended pregnancy. 3 decades avoiding an unintended pregnancy. That's a long time and a lot of work. And there's a lot of, kind of layers to the onion in going into that. So thinking about everything from the individual level, which includes an individual's family size goals, pregnancy intentions, their relationship status and health status, their own personal knowledge and attitudes about birth control, ability to afford contraception. At the interpersonal level, it includes, their partners, willingness of partners to cooperate in family planning, things like that. Organizational factors, where I think of the role of employment, given that we are in a society where health insurance is often linked to employment. So what the role of employment is, what the role is of the employer in determining what our health insurance coverage should be, and whether or not that should include contraception or not. At the community level, the availability of family planning providers, the availability of pharmacies, what social norms are around birth control. And then perhaps what we'll spend most of our time talking about today is public policy, which would include healthcare policies that govern whether or not contraception is accessible or affordable. So then I think the other thing to think about is whose responsibility is it? Whose problem is it to help us avoid unintended pregnancies? And I guess I think it's all layers of this onion, but obviously not everyone's going to think it's all layers of this onion. In thinking about policy, I do think it's important for public health and public policy to kind of take on unintended pregnancy as something that we care about, but not everyone would agree with that. And so I think that presents some of the problems that we have when we're trying to address the issue. So again, I know this group is very familiar with contraceptive methods, but just again, to kind of keep us on the same page as we talk about different methods going forward. So I'll try to be brief in this section here. This is just a pictorial representation of different contraceptive methods that are currently available. kind of lost my cursor there for a second. So thinking about what the most effective contraceptive methods are, we'll be talking a bit today about LARCs. LARCs stand for long-acting reversible contraceptives. So those are the ones circled here on the left side of the screen and include the IUD and the implant. These are really super effective methods, 0.05% failure rates per year. They do require a procedure for insertion. So the IUDs sit in the uterus while the implant is inserted into the inner part of the upper arm. But they are actually an order of magnitude more effective than sterilization, believe it or not. So they're just really effective methods. I do want to say, as a caveat, that even though LARCs are as effective as I said they were, and they are actually considered by the American College of OBGYNs to be first-line methods for women of all ages, regardless of parity, due to high efficacy and safety profile. I do want to say that I disagree with that statement. I think that there are many characteristics of different birth control methods far beyond just efficacy and safety that individuals consider when they're selecting what birth control method to use or not to use. And those characteristics are really important to people in different individual ways. So I think it's an overgeneralization to suggest that LARC should be considered first line for all women. So I just put that out there, happy to discuss that later if there's interest. So those are our most effective methods. And then we get to kind of the next level of the moderately effective methods. So these are our other hormonal methods, the most popular of which is the birth control pill, but it also includes the birth control patch, the injectable and vaginal contraceptive rings. And then we get into our least effective method. So this includes condoms, both male and female condoms that have failure rates upwards of 18% per year. And then we also include withdrawal and fertility-based methods, which probably have failure rates closer to 25% per year. So we really see the full range of efficacy, starting with our LARCs down to withdrawal and fertility-based methods. However, these are the most commonly used methods. So the male condom, sterilization, and the birth control pill are the ones that are, by quite a fair margin, the most commonly used ones. So I know all of that is review for everyone, but just kind of wanted to do a little level setting. So next, I'm going to do a little history. I hope there's some history buffs out there, because we're going to get back into the dark ages here, so to speak. So condoms, the earliest condoms in the United States date back to around 1800. This is not a real one. This is a representation of what one might have looked like, but they were made from chemically treated linen or from animal tissue, primarily from intestines or bladder. So those were kind of the earliest condoms that were used. And that was pretty much all there was available until we get to the middle 1800s. And that happened when Charles Goodyear patented rubber vulcanization. And that led the way to make the first reusable rubber condom, which became available in 1855. So strangely enough, when they made this first rubber condoms, they made them that only covered the glans part of the penis. So they were problematic because they tended to fall off, which we probably could have guessed would have been the case. But I thought that was of interest. So then we get to our first contraceptive policy that I wanted to talk about, and that's the Comstock Act, which was a federal act passed in 1873. So this was started by this guy named Anthony Comstock. He was not a lawmaker. He was a citizen, and he was a self-proclaimed anti-obscenity crusader. That was what he called himself. And he went to Washington with an anti-obscenity bill, and that was passed in 1873. It was officially titled An Act for the Suppression of, Trade in, and Circulation of Obscene Literature and Articles of Immoral Use. So the statute defined contraceptives as obscene and illicit, and made it a federal offense to disseminate contraceptives, advertise contraceptives, or disseminate them through the mail or across state lines. So, and then interestingly, this guy, Anthony Comstock, was then named special agent in the post office who was charged with enforcing the law. And violators could be punished with up to 5 years in prison and up to $2,000 in fines. So just pretty remarkable how much it was regulated. So then following the Comstock Act came a bunch of laws in states that were collectively called Comstock laws, also known as chastity laws. And they were really strict, mostly in the Northeast, the strictest of which was in Connecticut, which prohibited any use of birth control, even amongst married couples. So married couples could be arrested for using any form of birth control and were subject to 1 year in prison. However, in spite of these Comstock laws, condoms were being used, and they became more and more popular by the end of the 19th century. There was actually a survey conducted in 1900. I was shocked to know that there was survey researchers back then, but there was a survey in 1900 which found that 45% of women had said that they had used condoms to prevent pregnancy. So next on our timeline comes World War I. So now we're in the early part of the 1900s. And I was also surprised to find that the US military actually was conducting studies on STI transmission. And they actually conducted some studies that showed that providing condoms to soldiers actually significantly lowered the rate of sexually transmitted infections. However, in spite of doing this work, the United States was the only country with soldiers in Europe that did not provide condoms or promote their use. And they actually relied on educational messages to promote abstinence, which we can guess how well that worked. So here's an example of some of the educational messaging. So Surgeon Sage says, only a poor boob pays his money, loses his watch, gets the sif, and brags that he's had a good time. So by the end of World War I, there were 400,000 cases of syphilis and gonorrhea diagnosed in US soldiers. So I might argue that that was perhaps the first evidence that abstinence-only education doesn't work. Okay, so then we get, now we're in the early 1900s, and I'm sure many of you are familiar with the work of Margaret Sanger. So Margaret Sanger opened what's thought to be the first birth control clinic in New York, and ultimately her birth control clinics have evolved to what we believe is now modern day Planned Parenthood. But after she opened her first clinic, she was promptly arrested under the Comstock Act for distributing information on contraception. And actually throughout her career, she was jailed numerous times for similar activities and just being what was called a public nuisance in general. However, her work ultimately, really helped to eventually overturn the Comstock Act. So in 1936 was the United States versus One package, which allowed overturning of the Comstock Act, although it overturned the federal Comstock Act and all the restrictive kind of Comstock laws at the state level were still intact. And it's believed that as late as 1960, there were still 30 states that still had some sort of statute prohibiting or restricting sale or advertisements of contraception still on the books, believe it or not. So, however, this overturning of the Comstock Act was very significant, and finally condoms could be publicly and legally sold in the United States for the first time in 45 years, although they really were supposed to be only used for disease prevention and not for contraception. However, the overturning of the Comstock Act did pave the way for legitimization of birth control, both by the medical industry and the general public. And it was around the same time that diaphragms were being introduced. They actually were being smuggled illegally into the United States from other countries, but they were becoming more available and more popular. And interesting fun fact, Margaret Sanger's second husband was actually the first legal manufacturer and diaphragms in the United States. So then jumping ahead, the pill. So the first birth control pill was called Avoid, and it was approved for contraceptive use in 1960. However, it was still not universally available since contraception was still illegal in many states. And then we see a couple of very important laws come into effect. So in 1965, we see Griswold versus Connecticut. And this law gave married women the right to use birth control. This was actually a direct challenge to Connecticut's Comstock law. And the argument was that the Comstock law violated the right to marital privacy. So then in 1972 was Eisenstadt versus Baird. And again, Griswold legalized contraception for married women. Eisenstadt versus Baird legalized birth control for all citizens, irrespective of marital status. So this isn't really ancient history. This is kind of the era where I was born. So I don't talk about this with my parents, but this is kind of thinking about my parents' generation and what they might have had to think about and negotiate as they were trying to plan their own family size. As I think is relevant as we think about maybe more recent what's happening now in the Supreme Court, the reasoning and the language in both Griswold and Eisenstadt was right to privacy under due process clause of the 14th Amendment, which was also what was used and cited in Roe, as well as what is cited for the right to same-sex marriage. So I think there is some concern and speculation as that argument gets pulled apart in Roe, what could potentially happen with some of these other laws that were argued on the same grounds. Okay, so then we start seeing birth control methods that maybe we are now more familiar with and used to seeing. So in the late 1980s, we see the Paragard copper IUD come along, which is still in use. We see other IUDs come along after that as well. The hormone-containing IUDs, the first one, Mirena, came out in 2001, followed by some of the other ones in recent years. We see the first contraceptive implant, which at that time was Norplant, which came out in 1991. That became available. The current day implant is Nexplanon. And then we see, of course, Depo-Provera, which was is the contraceptive injectable. And then we see the contraceptive patch, the vaginal ring, and other contraceptive methods that we are now familiar with. So that's kind of our basic timeline of how we got to the methods that we are currently familiar with, as well as some of the early policies around contraception. So now I'm going to move to some more modern day policies that are the ones that are going to be subject of the research that we're going to be talking about today. So this is a little bit more recent, modern day. So we're going to start in 2000 with the Equal Employment Opportunity Commission ruling that companies that provided insurance for prescription drugs to their employees but excluded birth control were in violation of the 1964 Civil Rights Act, which prevents discrimination on the basis of sex. So that has been upheld in subsequent rulings. It's still in effect today. It applies to employers that have at least 15 employees. And it worked. You know, the percent of employer-based plans offering contraceptive coverage tripled to 90% in the decade following this EEOC ruling. However, the thing that's important to know about this is even though it required birth control to be covered in insurance plans, it did not say anything about what the cost needed to be to individuals. So that doesn't come later until the Affordable Care Act. So we're all familiar that the Affordable Care Act subsequently included a federal mandate that contraception would have to be provided without patient cost sharing. So that part is really important. So no out-of-pocket costs to the patient was a requirement of the contraceptive mandate. And that came into effect in August of 2012. So the first full year that would have been in effect would be in 2013. There were exceptions to the ACA mandate. So there were exceptions at that time to churches, to houses of worship, but initially there were no exceptions to other large religious organizations such as Catholic hospitals, Christian or Catholic universities, or other organizations that were owned by religious groups. The mandate required that at least one form of the 18 FDA approved contraceptive methods would be covered without cost sharing. So that didn't mean every single birth control pill that was available on the market. That meant one form of combined oral contraceptive, one form of the hormone releasing IUDs, one form of each of the 18 approved methods needed to be covered without cost sharing. So perhaps not surprisingly, this was controversial. And opponents of the ACA contraceptive mandate suggested that this was a direct attack on the religious liberty of employers. So as a compromise, the administration at the time decided to allow religiously affiliated nonprofits to request something called an accommodation. And an accommodation would be that the employer who had an objection would not have to cover the cost. The employee would still have to have the benefit of no cost contraception, but instead of the employer bearing the cost, the health insurance company would bear the cost. So that was the reasoning and the way accommodations were rolled out for religious nonprofits. Some of you may be familiar with the Hobby Lobby case that subsequently happened in 2014. And Hobby Lobby, they're based in Pennsylvania. They're like a hobby craft store, and they're a large employer in Pennsylvania. And they argued that it shouldn't only be religious nonprofits, it could also be corporations like theirs that were closely held for-profit corporations. And so as a result of that, closely held for-profit corporations could also choose accommodation from the law based on religious preferences. So now we see, potentially an increasing number of employers that are able to request accommodation from the law. However, again, those employees would still theoretically have access to no cost contraception, but it would be the health insurer, not the employer, that would be bearing the cost. So that was the case until 2017. Under the Trump administration, they released a new rule that said, hey, not just nonprofit religious organizations and not just certain for-profit organizations, but basically any nonprofit or for-profit employer, including private colleges and universities, you could actually also be exempt, not just accommodation, but fully exempt from the ACA mandate. And when I say exempt, I mean they don't have to require the health insurance company cover contraception. They can just say, no, thank you. This went through some legal battles, but in 2000, the Trump exemption fully went into effect with the court case of Little Sisters of the Poor versus Pennsylvania. We don't know what the effect yet is of this Trump exemption. And we also don't know how many employers are doing the exemption, because they don't have to apply for it. They don't have to register for it. They can basically just decide that they're exempt and tell their health insurance company that they want to be exempt from the rule. So this is going to be, I think, a little challenging for us as researchers to kind of understand what the effect of this as we go forward. Okay, so since that is more recent day, we will have to wait to see how we understand that, but I'm going to present some data now that is looking at some of the work that we've been doing around the effect of the ACA mandate. So we use data from IBM Market Scan Research Database. So this is a claims database of many commercial insurance plans. And we looked at annual study cohorts every year between 2006 and 2019. We just got the 2020 data set, but we don't have that data available yet. And we looked at women who were ages 13 to 49. In order to identify contraceptive use, we looked at contraceptive utilization claims. So we looked at procedural claims for IUDs and implants for the LARCs. And we looked at pharmacy claims data for other methods, non-LARCs, that would be dispensed at pharmacies. And in order to look at costs, we looked at the combination of copays, coinsurance, and deductible payments in order to estimate out-of-pocket costs for individuals. And we basically looked at what was happening before and after the ACA mandate. And what we're going to talk about today is contraceptive use and costs. We're currently actively working on looking at some other outcomes that may be of interest as well, like looking at how the mandate affect contraceptive adherence, and also looking at how it affects pregnancy spacing and outcomes. But let's focus now on use and costs. So this is a graph I'm going to show you that is from a paper that we published a couple years ago. And this, I'm going to show you some more recent data in a second, but you'll see why I'm showing you this separately here in a moment. So this is when we've only at that time had data up to 2016. And what you see here is two lines. The blue line is IUDs and the orange lines is implants. And the x-axis is years, the cohort years, and the y-axis is the percent of women in each cohort year who had a procedural claim for a LARC insertion. So what we thought we were observing is that, before the ACA mandate, which is, depicted by this vertical line, that there did seem to be some time trend, that there was already a increase in the uptick of LARC insertions over time. And then our question was, did this change in any significant way after the ACA? So what we did is we ran a logistic regression, which I'm showing you here, looking at whether or not post-ACA compared to pre-ACA was associated with increased odds of LARC insertion. So the adjusted odds here are odds of LARC insertion, and it is small, but statistically significant. We did see that there was a small increase in LARC insertions after the ACA. I do want to point out in order to kind of acknowledge that there was already this time trend of increasing LARC insertions. We also included a variable here for cohort year to try to control for the effect of the background time trend. So that's what we saw when we looked through 2014. So now more recently, we've been tagging on more recent years data. And I think you'll might see that it's a little bit less clear now what's going on now that we've added a couple more years of data after that first publication that we put out. So the X and Y axes are the same here. It's just that the lines have extended a little bit longer. And now that we've done that, you can see it's a little less clear, at least from this visual representation, what's happening here with the years. And then I'd be curious, actually, if you guys would help me speculate here what might be happening in 2019. Again, I think we need to add on 2020 data to really see what's going on. Just in my early speculation, I know that during the Trump administration, there was a good amount of fear that the ACA contraceptive mandate, or maybe the ACA in total, would be overturned. And so there were several reports that there was a uptick in LARC insertions during that time, because perhaps women were aware that that no cost benefit may not be there later. So maybe there was an uptick at that time, and then, you know, maybe all the women who wanted to get LARCs got their LARCs, and maybe that's why we might be seeing a downtrend. But I don't know. I don't know. I'd be interested in entertaining some thoughts about this, if anyone has any. So then the question is what happens to costs, right? So this graph here shows what we observed with costs with both, again, the IUDs in blue and the implants are in orange. The x-axis is still years, but the y-axis now is dollars. So this is the mean out-of-pocket costs per LARC insertion. And as expected, we saw that there was a sharp decline in out-of-pocket costs that came after the ACA contraceptive coverage requirement was implemented. And luckily that has generally continued to go down, although we're very curious to see what is going to happen with that moving further along. So what about other methods? This is the oral contraceptive pills in blue. And then at the bottom, you can see all stacked on top of each other are the injection, the patch, and the ring. We still need to take deeper dive into this, but I think we'd all agree that there's not a whole lot going on, maybe when it comes to use characteristics of these other methods. But similarly, when we look at cost, we do see, at least with the pills, the injections, and the ring, that there was also a sharp decline in mean out-of-pocket costs. This is cost per month for these methods. So there was a sharp decline. What's happening up here in the gray line with the patches? Well, I would speculate around the same time as this mandate went in effect, actually in 2014, the patch that had been around for a really long time on patent was called Ortho-Evra. That went off the market and was replaced by a generic version. And so, as I mentioned earlier, the ACA only mandates that you need to cover one brand within each type of method. So I wonder if with the change in brand, if the plans didn't keep up, and so we didn't see the same drop in cost. I don't know, we're still looking into that, but that is a peculiar finding that we had there. So I spoke about the federal coverage policies and what we're doing about kind of understanding the effect of those. But what's going to be much more complicated is looking at state policies. So I mentioned, actually, I don't think I mentioned earlier, sorry, that before the Affordable Care Act mandate went into effect, there were actually 28 states that had what are called contraceptive parity laws that are, reflective of what the EEOC ruling were. Those are mandates that require health insurance, cover prescription contraceptives, but they did not require anything about cost. So none of those contraceptive parity laws mandate that there needs to be no out-of-pocket costs. They just needed to be covered by the health insurance, and it could be up to the employer to what degree it would be covered. So I think it's important to know that state policies don't have jurisdiction over self-insured plans. So self-insured plans are plans where the employer, typically large employers, they collect premiums and pay medical claims themselves. They'll often have a third-party administrator that helps administer those and collect the claims and whatever. But these state laws do not have jurisdiction over self-insured plans. And it's estimated that 60% of workers, insured workers, are covered under self-insured plans. So these state laws would not have the same reach as a federal mandate. And then what subsequently happened, in more recent years following the Obama administration, is that 16 states actually have passed laws that are now they've replaced their prior contraceptive parity laws with laws that are reflective of what the ACA mandate said. So not only do employers need to cover birth control, but they need to be covered with no out-of-pocket costs. So this is kind of our next task, to study these, but I just thought you might find it interesting where all these states were. So I'm going to show you maps in 5-year intervals. This is 2005. I'll show you 2010, 2015, and 2020. So back in 2005, so this is before the contraceptive mandate and the ACA. The light blue states are states that have no policy. We're in good company of each other, Tennessee and Pennsylvania, no contraceptive coverage policy. The kind of turquoise color states are the states that have had a contraceptive parity law. So some sort of law that said that contraception needed to be covered. So as we move to 2010, a couple more states added on some contraceptive parity laws. 2015, one more state was added, so it's about half and half now. And then we get to 2020, and now we see some darker blue states, and these are the states that have now replaced their contraceptive parity laws with new laws that are codified to the ACA, again, meaning that they require no cost coverage. So this is kind of the current map of state policies. Pennsylvania and Tennessee were still in the light blue. So I'm going to stop there. Obviously, we still have a lot of work to do in addition to kind of figuring out what the effect is of state policies in addition to federal policies. We want to better, this is commercial insurance that we're talking about because these are the policies that are affected. But, what about women that are covered on Medicaid or women who are uninsured? There are many states that have added policies requiring coverage of immediate postpartum LARC. So what is the effect of that? One of our junior faculty K recipients is studying that now. And as I mentioned earlier, I think I'm curious to better understand what will reversing a Roe v. Wade mean for not just abortion access, of course, but how might it have downstream effects on contraceptive use or contraceptive policy if we think that the legal precedent that was the basis of Roe v. Wade was also the basis of other contraceptive policies? Do we really think that those are potentially in jeopardy or not? Is that something we, as researchers who want to be doing our best to inform policymakers, are those things that we need to pay attention to? So I spoke a little longer than I thought I would. I'm sorry, but I just want to thank everyone for your time. This is my family in Hershey, and this is our dog Wilson saying hi to everyone. So I'm going to stop sharing, and I'm really excited to see what thoughts people may have. Thank you.
Well, first, let me say thank you, Dr. Chuang, for this wonderful presentation. And it's sometimes, you know, we are focused, our work is focused on the most current literature, you know, modern policies, as you mentioned, the present and the future. And we don't always take a look at how, you know, the past shaped, you know, the present. And so thank you for that window, you know, into the history of contraception. And because it has been a long journey and lots of steps and phases and social movements, you know, and I guess the fight continues, right? So thank you for that. So questions, comments from our audience?
I have a question. Can you hear me?
Yes.
My name is Alan Archer. Sorry for the lower. My name is Alan Archer. I'm a first-year medical student and PhD student here at UTSU. And obviously, we're in great company with a lot of wonderful researchers here. But I'm curious, from the clinical perspective, how do you see potential returning of Roe v. Wade impacting your clinical practice or your colleagues? Just curious to hear kind of your thought process on that as we approach, you know, decision for Roe v. Wade. Curious.
Yeah, thank you for that question. So I think I don't fully know the answer yet, but I'll tell you what we've been talking about anyway. So, you know, after the leak came out, I think several of us who care about this issue, our heads were spinning and we kind of did nothing for a little while because I think we just didn't know what to do with ourselves. There's a group of us who are very interested in how our academic medical center will respond, who have been getting together and thinking about this. We, as an academic medical center, do not provide abortion care here unless it is a life-threatening situation to the pregnant individual. But we want to be prepared for what may happen. There may be more people from neighboring states in life-threatening situations who get sent to our hospital. Are we going to be prepared for that? So we neighbor Ohio and West Virginia, which are states that have one of those laws that as soon as Roe v. Wade goes down, abortion is going to be illegal in those states. So that will probably most likely affect our colleagues in the western part of the state, but we know that it's, I mean, you know, we border part of West Virginia and central PA too. So we know that we need to be prepared. There is a outstanding commentary that just came out maybe 2 weeks ago in the New England Journal of Medicine, written by Dr. Lisa Harris, an abortion provider and OBGYN at Michigan. And that paper is really about how academic institutions need to be prepared for the overturning of Roe v. Wade. And she talks about everything from, you know, not only how it's going to affect clinical care, but as you as medical students are going to be thinking about, how does it affect us as educators? Are students and residents going to even want to come to our institution for their training if it's a place that doesn't provide care that many people consider to be healthcare? And, you know, if you're in a state that doesn't legally provide that care, are you getting the education that you want? So anyway, I definitely recommend that article. So those are some of the things that we've been thinking about. And as clinicians, on a personal note, I'll tell you that I'm a general internist. I do primary care. I do lots of contraception. I don't provide abortion care. But this is a situation where this old dog is going to start learning some new tricks. So I did abortion training when I was a medical student and a resident. I completed my, I was a medicine resident during the Clinton administration. And I thought, you know what? I got colleagues out there who've got this. Like, it's okay if I don't end up being an abortion provider. But now that has changed. So me and another colleague in general internal medicine, we are actively doing our abortion training again. And we are getting credentialed to start working at Planned Parenthood in the next couple months. I don't know if they will actually need us, but our thinking is if we're able and willing to provide medication abortions, that'll free up our colleagues who are able to provide procedural abortions to people who are showing up later in pregnancy because they're traveling from other places. So sorry for that super long-winded answer. That was probably way more than you wanted to hear, but thank you for the question.
Very much. That's wonderful. And it's really inspiring to hear that you are running towards the fight rather than away from it. And, you know, as a medical student, that is really reassuring to hear. So thank you very much for everything.
Thank you. Other questions or comments for Dr. Chuang, or thoughts about her presentation or how some of the work that we're doing, you know, particularly with Medicaid claims, sort of has parallels to what she presented?
I kind of feel like that comment was directed at me.
I was hoping you would speak up, Dr. Hale.
Yeah, I do have a question. This is like a totally a nerdy, geeky data question. So I'm sorry it's not as kind of grandiose as Alan's questions and things like that, but like this is something that we've been talking about quite a bit. So you're using claims data to effectively track, you know, different contraceptive methods, you know, using billing codes and things like that over time. Like, how confident are you that billing data can pick up some of the methods that maybe are kind of less procedurally intensive, like pills and things that might not, like there might be a lot more churn in the data, and they might be harder to track consistently over time? Because we've been making the argument a lot that, you know, IUDs and implants from an analysis perspective are much cleaner than pills and patches and things like that. So we've tried to avoid making too many statements about some of these other methods and focusing on those, but you do that at the risk of overemphasizing the longer acting methods, which can get you in trouble. So we're kind of like trying to thread the needle here of what to focus on when we look at claims data. So I'd really like to know like what your thoughts are on the reliability and kind of thinking about how to look at those methods within claims data over time.
Yeah, I 100% agree. And actually, like the publications that we've had so far around this data has only been the LARCs for very much the same reason. It was just cleaner. It was easier to get the data. It was easier to analyze and interpret the data. I don't have any great answers for you. I think we are like-minded in this. We've been a little afraid of, you know, how reliable a lot of that data is. And certainly just because someone has, you know, if someone has a claim for an IUD, probably they do have an IUD in their uterus. But if someone has a claim for a birth control pill, that doesn't necessarily, it certainly doesn't mean they took those pills, right? So it's just really, really squishy, I think, in some ways. So I agree. And I think that's just maybe an inherent weakness of the claims data that we need to recognize.
Okay, so that was a totally validating answer, so thank you.
Okay, good. Thanks.
It's 1:03, but if there is one final thought or question, I guess we'll go ahead and take that.
So I was just going to make a comment on the slide that you showed where you extended the trend lines for IUDs and implants out to 2019, and it showed the the slowdown in 2018 and the drop in 2019. And one thing that I think happened around that time, I think it happened around March 2019, was what's often called the domestic gag rule for Title X, and it caused a bunch of states it caused a restriction of Title X family planning clinic capacity in a bunch of states, which those Title X clinics are a big provider of the long-acting methods in many states. Some states were unaffected, but that could be something that contributes to that drop, though it probably doesn't explain the entire thing.
Oh, I love that suggestion though, Mike. I think that gives us reason to look at if there is more of a decline by state, because that would really show us if that could be the effect. Cool, thank you. Thank you.
Yeah, and thank you so much for your presentation. This is wonderful.
Thank you.
Well, thank you, everyone. Again, thank you for staying on, for a few extra minutes. Dr. Chuang, thanks again. And again, it's, as you can see, there's a lot of common, interest and lines, of work that perhaps with similar, goals and similar methodologies, but different populations. So I certainly hope that we can continue this discussion and engage, further with each other and with our teams, and perhaps identify opportunities to do some collaborative work moving forward, or at least learn from each other's experiences.
I would love that and really welcome it. Thank you so much. Really appreciate the opportunity to meet with all of you. Thank you.
Have a great rest of the day, everyone, and a wonderful summer.